Good morning, everybody. So you get to hear my second grand round. I did one 2 years ago for my chief year, so must not have been that horrible since you invited me back. All right, so I'm going to talk about, quote unquote, my decade with Davis. The title sounded much better than 9 years with Davis, so it's not quite a decade, but I'll tell you a lot about what I've done. So disclosures, I don't have anything fancy, but this talk is 100% my opinions. None of my bosses, as you'll quickly find out, had anything to do with this or say about it. Probably half the people in this room, unfortunately, won't know of half the individuals that I talk about or care who they are, but that's all right. And it's possible that I may not teach you anything useful that you'll need in your everyday careers, but at least while we're doing this, we'll take a step back. Hopefully we laugh a little bit. We'll reminisce about where Davis was, the Department of Surgery, 9 years ago, where we are today, and also some things that have just changed in practice pattern that have accomplished in just the short time that I've actually been a doc. And then really my goal is to also, at the end, provoke some thought and reflection for, again, where we've come, all the success we've had, and then also hopefully, for all you guys in your career, and then also where we can go in the next 9 years. So, like I said, not quite at the finish line. I'm not tenured here, so I am getting kicked to the street going to Sutter later on. So, haven't even graduated yet, and I've been called one of these. So, Dr. Young gave his grand rounds a couple months back and said that I'm already obsolete, right? That, I'm the last traditional fellow to go through this program, and now we have these fancy I-6 residents like Sabrina and Anna and everybody that basically, are chomping at my heels and making me obsolete before I even get out in the workforce. I personally don't think so. I consider myself more of one of these. And it's a cockroach. So most of you probably have heard me say this because I have a lot of people come up to me and be like, geez, Louise, you're still here? You haven't graduated yet? How freaking slow are you? And I just say I'm like a roach. Davis can't get rid of me. I'm resilient and I keep showing up every day. So, and it is true, the rumor was around, and it is true that I've been here so freaking long that HR doesn't even have a PGY status for me or a pay scale for me. So, like most HR reps, so what do? So I get my contract for this past year, and they want to basically start me back from the beginning and pay me less than I made the years before. Fortunately, with the good graces of Drs. Cook and Farmer, they worked it out and actually gave me an exemption. So there actually was a PGY 9 for this year. But this is still a 2018, so hope none of you go that far because you won't get paid. So, going back to this and just kind of reflecting when I was sitting down in a coffee shop, I'm like, what in the hell am I going to talk about? I remembered back to when I was a high school senior. You guys remember the show, Trauma Life in the ER? Probably no? Okay. Well, it was popular with, I guess, my nerdy friends in high school, but I watched the show quite a bit, and I distinctly remember one episode as a senior in high school, and I was thinking medicine at that point, not sure, but was thinking it, and I remember watching this episode that had a congenital cardiac surgeon. He was in his last year, and they were talking about how he did 18 years of training after high school, and I remember stopping at that moment, I was like, no freaking way, right? I was like, all right, congenital cardiac surgeon off the list, there's no way I'm going to spend that. I've held true to that. I've only done 17, not 18. So, my talk, Decade with Davis. What does that come from? It comes from actually kind of a colloquialism from this guy, Dave Sabiston. So, Dr. Sabiston was born in 1924, actually in North Carolina. He actually became one of the most respected, surgeons in our modern surgery. So, probably half of us in this room have his textbook of surgery, right? So, he went to med school at Hopkins and graduated and then finished his surgical residency under Blaylock. And then went to the military, and actually that's where he did some research at Walter Reed, and that's where he got his inspiration and pursued his career in cardiothoracic surgery. So I thought it was very fitting with this decade with Dave that I'll talk about here, and me going into cardiac surgery and spending almost a decade here at Davis. But basically he studied basic research in coronary physiology, revascularization, was actually the first to do a saphenous vein graft on a human being. He, after his military commitment, went back to Hopkins and quickly shot up the ranks, made full professor at a very young age. And then when Blaylock died in '64, there was some internal turmoil with Hopkins, and basically Blaylock was a very strong personality, and they knew that they wanted to bring outside blood to be the next chairman. Well, Duke, one of the deans at Duke at that point, took advantage of that, realizing that, it's going to cause some strife amongst the people at Hopkins, and actually recruited Sabiston to come to Duke and made him the chair of surgery at the age of 39. And he held that position for the next 32 years and actually trained 154 chief residents, 95 which became cardiothoracic surgeons. 41 of them became either division chiefs or department chairs. He died in 2009, and his eulogy, at least on CTS.net, was written by Dr. Chitwood, who was one of his trainees, and basically talked about how, as it says here, right, Dr. Sabiston was a very tough taskmaster. His focus was always on excellence to be obtained by hard work, attention to detail, and basic knowledge. These were the basic tenets of our residency, and he often spoke of Osler's master word in medicine, work. He expected more from residents and got more. I think that 100% echoes true to not just CT surgery, and Dr. Chitwood, who was also a CT surgeon, went into how we should follow those tenets, for the next generation of cardiac surgeons. But I think this absolutely holds true to my time here. We can play this whole game, 6 degrees of separation. We do have faculty here. You heard one of them today. We have people who went to med school at Duke. We had people who did fellowship at Duke, and Dr. Farkas was faculty at Duke. But you know what? I wanted to make this time and this 1 hour kind of about us, right? UC Davis Health, Department of Surgery, where we are, what we can be proud of, and where we can go from here. So a lot of it that has the big change that I can see certainly is under the brainchild of Dr. Farmer. Dr. Farmer was not here when I first started, and since she's being here, she's actually added 28 new faculty that I was able to count going through websites and research since the time that I've been here. And this has been huge for my education, right? So 40% of the faculty here at UC Davis Department of Surgery is new since I started. So I've gained tremendous benefit from all the hard work of Dr. Farmer and all the individuals that you see here. So Dr. Keller, you heard him speak a couple weeks ago about, he's been here 8 years, and it was something like 2 million days and counting, which I didn't want to repeat all of that, so I tried to think of another context to kind of say what all that's happened in Davis in that time. And if you look, Davis has trained 13,000 residents in the time that I've been here, and Dr. Keller has been here. And so that's 13,000 people that walked in front of us, right, through the line when you and I are still here. So what's my talk really going to be about? All I said is how freaking old I am. Well, my talk of going back and kind of reminiscing on all this stuff, really, right, 9 years is not that long in a career at all. And yet there's been tremendous change in also just the way and practice paradigms of things that I learned as a medical student that are now we treat totally different than we do today. And also things that I've seen and come across that I'm like, I never learned any of that basic science in med school. It didn't exist just in the short time that I was sitting in med school that now we do every day. So I'm going to kind of go through a couple of those things with you. Particularly, I'm going to do general thoracic surgery at Sutter, so we're going to talk about things that are quite relevant to what I'm going to do with my everyday life. But first, we're going to talk about my first day as a doctor. So literally, it was day one. This guy, Brock Anderson, he was my chief. Those who remember, Dr. Anderson is actually a poster child of this program. He was a very hard worker, great surgeon, did his trauma critical care fellowship here, and ended up going into practice in Casper, Wyoming with his dad, who's a general surgeon. He does everything. He does vascular surgery, he does critical care, he does trauma. He was helping the cardiac surgeon do coronaries. I mean, the guy does everything. He was my chief that first day. And this goes on the tenet of, for Sabiston on basic knowledge. So I know nothing, right? It's day one, I know nothing. So I remember I get a call from a nurse. I got the page the first time, barely know how to answer it, but I get the page from the nurse that says, Miss Such and Such is on Protonics. Dr. Anderson put her on it, but she wants her home medication, which was, PPI-Y. I don't even remember what it was. And I was just like wringing my hands going, oh my goodness, I don't know hardly what those medicines are, let alone, Dr. Anderson's so freaking smart. He's been here, 20 years, and of course he picked that specific perfect medication for this patient, right? I don't know what it is, but I know he picked it. So we've all kind of been through that, right? You think your chief knows everything and every little thing matters, right? So it constantly reminds me of this. See when we get to play.
Actually just paged me to find out how much Tylenol to give to Mrs. Lentner. I was worried it could exacerbate the patient's. It's regular strength Tylenol. Here's what you do. Get her to open her mouth, take a handful, and throw it at her. Whatever sticks, that's the correct dosage. Under those circumstances, you compromise her nose walking.
Right, so of course we went on, and I talked to Dr. Anderson at the time, and I was like, well, I don't know, I didn't change it, didn't do anything. He just laughed at me, and so once I saw that kind of clip years later, I was like, that's exactly what he was thinking in his mind. Like, whatever, newbie, just you can change it, do whatever she wants. I don't care. So first thing that's kind of changed in the paradigm of what we do every day now, right? So one of the tenets when I was a third-year med student, I'll never forget when I was on acute care surgery that they talked about, they're like, never let the sun rise or set on an empyema, right? Very dangerous to do that. You got to take these patients to the operating room, drain it, do all this stuff. I'm just this nervous student going, oh, yeah, noted. We'll do this. We'll take these patients. Well, not to say that we don't take patients to the operating room, who are critically sick, septic, for empyemas still to this day, but that traditionally has been a surgical disease. Well, I would argue now, in 2018, just 7 years after this paper that I'll talk about in a second, comes out that probably is not the case. Now it's changed primarily from a surgical disease to primarily a medical disease. So what is this paper? It's called the MIST-2 trial. I recommend everybody who's going to be a surgeon read this paper because you will, in some context, some form, no matter what you do, come across empyemas. So what they did is it was a randomized controlled trial. They looked at 210 patients, 4 arms, double placebo, TPA plus DNase, TPA, placebo, DNase, placebo. Pretty simple, right? Everyone went to the 4 arms. Primary endpoint, a little bit weird, but is somewhat relevant, where then they looked at, so they instilled these products twice a day for 3 days. And then they looked at, from day 1, the chest x-ray, day 7, chest x-ray, and what percentage of pleural opacity changed. And their secondary outpoints were actually referral to surgery, i.e. did these patients ever need surgery, duration of hospital stay, and total adverse events. It's actually a pretty staggering study. So of those 4 groups, the only one that actually showed any difference whatsoever outside of the placebo was the TPA and DNase. And right, this is MIST-2. MIST-1 actually looked at streptokinase, no difference. There's been a lot of different iterations of this. This was the first big study to actually show that there was a difference with these 2 components together. Also, surgical referral, which is more relevant to what we do, right? At 3 months was only 4% with the dual lytic therapy versus placebo in the other 2 groups, right? Relevant. Also, if you look, almost a 7-day shorter hospital stay. We're talking about today, right? We're arguing just a couple days, in hospital stay. With this and lytics, these people are getting out almost a week sooner than their counterparts. And the adverse events didn't actually differ significantly between those 3 groups. So, like I said, today, I would say we, depending on where in the process they are, how long they've had this empyema, certainly we take these patients to surgery, with some frequency, but I'd say the majority now we're able to treat with just a little pigtail and some drugs through the chest. Next story. I can't believe I'm going to freaking tell a room of 100 people this story, but this guy, Eric Nelson, also the class of 2010. Okay, so he was my chief. We're a couple months in at this point. I was on Dr. Bold's service, surgical oncology. So this is a good fail of attention to detail. Okay, so I say this in this way intentionally. We had 4 males on our service because I'm pretty sure if we had 1 female, they wouldn't be this stupid. So 4 males on our service with the leadership of Dr. Nelson. We're rounding in the morning, 6 a.m. as you usually do, racing through patients to go see everybody, see how they're doing, and we stop at this lady's room. And I don't even remember what surgery she had at the point, but we're talking with her, and things seem like she's doing fine, and we kind of do our thing, and us interns are kind of taking notes on whatever Dr. Nelson wants to do. And as the 4 of us start walking out of the room, she goes, well, excuse me, guys, did you realize it was my birthday? And the wise Dr. Nelson decides that, oh, I got a good idea. Okay, no, none of us realize it's your birthday. Why don't we sing you happy birthday? So we start going, 4 guys, 6 o'clock in the morning, happy birthday to you. Start singing this song. Right at the point, right? Happy birthday to you, happy birthday to you, happy birthday, dear. And as we hit that, all 4 of us, eyes wide open, look at each other, and we're like, oh, right? And we're like racing like through our lab coats, trying to grab like our our sheet of like our names, and we're like scrambling. Of course, we don't make it in time. None of us do. And as that part goes, 4 guys in synchrony is like, blah, 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 blah. Right? Most freaking embarrassing thing I've had in residency. And this little lady just like, okay. You're taking care of me? Okay. Yeah. Attention to detail, right? Learned that lesson pretty early. Of course, I blame Dr. Nelson. All right. Next thing that's changed. Lung cancer screening, right? Huge. It's a new hot topic. If you look, this study that I'll talk about has been referenced over 4,000 times already. Okay? So lung cancer screening. So overall for lung cancer, anyone that's diagnosed, you have about a 16% chance 5-year survival, right? Horrible. We all know it's asymptomatic, we catch it late. There's lots of reasons that's the case. It's a bad actor, aggressive, yada, yada. A lot of people have looked at this. A lot of smart people have looked at this, right? Over the years, they've done chest x-ray surveillance in studies, no benefit. They thought, well, maybe if we look at people's sputums, we can catch and see if they have cancer cells in there. Maybe that will be cost effective. No benefit. So, 2011 again, this study came out. The NLST. Again, anyone who's going to be a surgeon should probably know at least of this study. So they looked at almost 54,000 patients, and they were high risk for lung cancer. So they were, the ages 55 to 80, they smoked at least 30 CAC years, and they had quit in less than 15 years. So then they looked at low-dose CT scans versus chest x-ray. Okay? With that study, there was a relative reduction of mortality of 20%. 20%, right? So pretty staggering numbers. Now there's a lot of complexity that goes along with this in terms of, more procedures were done, of course, with some false positives and some morbidity occurred with that. So it's not just, clean cut, I'm going to stamp my fist on the table and I'm going to save 1 out of 5 people's lives without causing any harm. It's not that simple. To the point where actually Medicare makes you document before they will pay you for doing this, that you actually have to say that you had the risk benefits discussion of patients and realize that increased procedures and so on. So I'm not saying it's perfect, but we finally had a study that maybe will benefit some people for lung cancer screening. So now the U.S. Preventive Service Task Force actually has put out recommendations. Again, 55 to 80, 30 pack year, and quit in the last 15 years, right? Grade B data to say to do this. Medicare now pays for this. All right, next is talking so one of the other things that Dr. Sabiston used to say is he would quote David Lloyd George. David Lloyd George was the Prime Minister of England back in the day. So one of the things that he would say all the time is don't be afraid to take a big step if one is indicated, because you can't cross a chasm in 2 small jumps. So when I read that, instantly Dr. Holcroft's face came to mind. And I think of Dr. Holcroft all the time. I hope most of you know Dr. Holcroft. He was, Ben, you probably remember his PI number, something like 53, right? So you guys all know your PI numbers. He's been here a long time. Very smart man, very dedicated to the education of all of us surgeons. And the tenets that he has said, ring in the back of my mind literally every day. But I'll never forget the day I was a new 3rd-year resident on trauma. Dr. Holcroft was my staff. It was a Saturday. Started like any other Saturday. Of course, as we heard Dr. Utter talking, right? Pagers going off the hook with consults here and there and traumas left and right. Well, we had a trauma for an X-lap maybe half hour before the scenario that I'm going to tell you. And so my chief that was on with me was doing this X-lap. I get a 911 page, and as we all know, the 3rd-year resident's responsible for going down, as with the attending, Dr. Holcroft. So we go down, I run this trauma code, think everything's going good. The guy's got this big old freaking, piece of towel on his neck. It's just saturated with blood, stabbed in the neck. So we go kind of do our thing. He's stable. We have him take it off. It's like flying across the room, right? So Dr. Holcroft, in his usual kind of intonation, all right, Sterling, what would you like to do with this patient? I was like, I know this answer. This one's easy. The blood's flying across the room. I'm like, sir, I want to take this patient to the operating room for a neck exploration. Great. I agree. Why don't you get him up to the operating room and I'll join you eventually? And I was like, what the hell does that mean? So, of course, you don't say that to his face. You're like, yes, sir, I got this, And all I had was a med student. I had no interns, no mid-levels, and I'm like a 2-month-old 3. Done maybe 2 carotids in my career. Right? Watched carotids. And so I'm, nervously taking this patient up to the operating room, hoping I'm going to see him. Where's he going? Not seeing him. So I'm frantically texting every chief I can think of that might be available, right? I'm like, where are you? You here? Can you help me? Can you do this? Saturday. No freaking chiefs in the operating or here unless they're doing something, right? So I either get no responses or, oh, sorry, busy, you're not here. Well, I happen to see he's actually staff here now. Toby Steele. Him and I were classmates, good friends. He's an ENT attending now. We crossed paths as I'm going to the operating room. I was like, hey, Toby, what you up to, buddy? Sure enough, he's like, oh, I'll come help you. So we go in. I'm thinking, I'm handling business, right? I'm being resourceful, getting everything. Dr. Holcroft, he didn't leave me, right? He did this intentionally to see how I would handle stress. He knew that the patient was stable. He was not far away. So as soon as we get the patient and get ready, of course he walks in, right? But what he didn't expect was all of a sudden he had a ENT resident in his operating room scrubbed in with me. So he was, that was the first thing he said. He comes in, he's like, what in the hell is an ENT resident doing in my operating room? I called him. So it was a good lesson learned for me, though, right? Like, you have to take that big leap. He wasn't going to let me fall, but to grow as a surgeon, you have those big leaps sometimes. We've all had them, right? And then you, for lack of a better word, you get a little hair on your chest and you get bigger, better, stronger. Some of that comes with, stress in various scenarios, this being one of them. And so I certainly look back fondly on that. When I see this cross the chasm, big jump, I think of Dr. Holcroft. Next thing that's kind of changed in our time since I've been a doc, checkpoint inhibitors. I mentioned that there were things in basic science, right? None of this existed when I was going through medical school. So for the relevance of this talk, the nuances behind all these, not pertinent. But needless to say, so there's these checkpoint inhibitors. Their job is to basically reactivate your immune system against tumor, right? So one of the ones that they've been around for with melanoma and renal cell cancer and stuff for quite a long time. Lung cancer, it's a relatively new thing. So the one that we do with most is the PD-L1 inhibitors. And so, again, it binds to that ligand and reinstates your immune system, if you will, to try and attack cancer with your own immune system. That thing's been done. I remember reading books in high school of people trying to accomplish this. Now we're starting to get closer here in 2018, about 25 years later. So, big paper that came out, just published in 2015. There was some earlier than that, but really where it started showing, rubber meets the road is only in the last couple years, showing that PDL actually as a second line agent. So these are patients, stage 3 and stage 4 non-small cell lung cancers that, I think I have another slide with it. No. Non-small cell lung cancers that failed their first treatment. And so then this is kind of like a salvage treatment for them, trying with this nivolumab was the first one, or you guys have Optruda, that's another name for it. If you see it, there's posters like around the city. Anyways, they did this study, and so when you're on second line treatment for non-small cell lung cancer, your kind of median length of survival is about 8 months. With this medication, the median survival was 17 months, right? You over doubled the patient's lifespan with this medication. So that was very reassuring and kind of stirred up, a lot of kind of research where now if you look, there's dozens of studies going on with all these checkpoint inhibitors, and it seems like another medication came out about every month and about every week in our tumor boards that we talk. There's a new study to do this and this combo in first line versus this. So it's a very interesting part of the field that I'm going to go into, but it's things that, again, that I have to go back and read that didn't exist just 9 years ago. Now we can talk about attention to detail in the operating room. I bet you Dr. Young remembers this story as well as I do. So this was my either first or second week of fellowship, right? And I'd done 7 years of general surgery here, and I'd spent some time in the operating room over the first 2 weeks with Dr. Young. And, mainly as the first assist role, right? He's showing me about the cardiopulmonary bypass and how we do it and the steps to put somebody on, so on and so forth. Well, today's the first day that he's going to let me throw those stitches to cannulate the aorta. Remember this? I do. So the way you do it is you put 2 purse strings on the ascending aorta, one with the tails going towards the surgeon, one towards the assistant. Then you do what I basically spent the last 7 years of my training trying to avoid, right? You stick holes in things like the IVC, SVC, aorta, all the stuff that I'm told to not do. That's what Dr. Young's telling me to do. So we do it, right? You stab the aorta with a knife, literally, stick a cannula in between those purse strings. I accomplish that, get the cannula in. I'm like, okay, good. I can stop sweating now. Did okay. We go to pull those purse strings. Whoop, whoop. Both of them come right out. Right? So now I got a hole in the aorta, or Dr. Young has a hole in the aorta put in by his nice resident, and no control, right? No stitches, no nothing. And I just remember looking at him going, oh my goodness, he's going to fire me today. But he held his composure, and he said, which he rings with me all the time, he said, Sterling, you pay dearly for every mistake you make in the operating room here. Attention to detail is critical, right? It's true every day, and it's particularly in CT surgery. Every stitch, if it's not done perfect, you pay dearly. So fortunately, he got me out of that bind there, and the patient did tremendously well. But I remember, probably thought the same as you, right? Like, this might be a long 2 years. I don't know. Next thing, IRIS, enhanced recovery after surgery. It's a topic that we hear of all the time, right? So I'm not going to say that I was here before this concept started, because it actually started in 1997. I was still in high school. But like most things, it takes a long time to get traction. So it started by these general surgeons that focused on colorectal surgery in Northern Europe, but it really didn't actually become a society with guidelines until the society in 2010 and guidelines in 2012. And I would say around that 2012 or so is when that buzzword started showing up here at UC Davis. ERIS, early recovery, enhanced recovery, all these kind of acronyms on what that means. We started seeing protocols on how to help patients and better streamline their postoperative care. And some, for the matter of preoperative care. Well, that same kind of buzzword is starting in thoracic surgery. So I went recently to Arizona and for a conference, and one of the kind of symposiums that was talking was this TERS, or thoracic enhanced recovery. And this paper just blew my mind. I heard the guy the PI behind it, go up and talk about it, and I was like, there's no way. So basically what he did is he took a cohort. So he took his patients. It's in Virginia. It's a private practice hospital. It's very prolific, very busy, but actually they're highly academic. So what he did is he took his patients before he decided to do this TERS stuff and after. And the ERAS piece that he did, I thought when he was saying it was crazy. So all patients go from the pre-op area and walk to the OR and lay down on the table so they don't get wheeled. And that's all for kind of like a cultural and also just kind of state of mind or point of reference of like, there's nothing wrong with you right now. Why do you need to be pushed in a bed to the operating room? All patients were supposed to get up within 60 minutes of hitting the PACU after this operation. These are all lobectomies, right? So after hitting the PACU, 60 minutes after that, they're to be in a chair. And before anybody can get any pain medicine whatsoever, they actually have to walk. I'm like, that would never freaking work here at UC Davis. And then, while they're in the PACU, they have to walk 250 feet. And if they want to see their family, they have to walk from the PACU to go get their family in the waiting area and bring them back. And then they have to, which, our patients go to E6 quite a ways from the PACU. I'm not sure their distance, but they walk from the PACU to their hospital room. Right? So very, very aggressive early recovery, right? And the piece for thoracic surgery, right, the killer for these people is pneumonia, right? So what did they see? What did they find? So they actually reached their achieved goal of all of those things I just described in 61.5% of their patients. And 91% of them were able to walk the 250 feet while still in the PACU. We've never had a single one unless they spend 3 days in the PACU walk 250. And then their median length of stay, 1 day versus 2. Quite frankly, yes, that was significant. I wouldn't worry too much about that. 1 versus 2 days with these lung patients, there's a lot that goes into that. But they had tremendously low rates of pneumonia, right? 0.7%. It's crazy. It's unheard of. Most, 5%, 10% pneumonia rates in these patients. 0.7%. And then their AFib rate, 4%. Thoracic surgery generally carries a 15 to 20% of post-op AFib. So huge reduction in these things and the killers for these patients, right? And another interesting piece, which is no surprise, but if you look at this bottom piece, right, target goal was achieved greater in the late piece versus the early, because it's exactly like I just said, right? You have to convince all these PACU nurses, floor nurses, they're all saying the same thing that I am. I'm like, you're freaking crazy. There's no way we're going to do this. But once people kind of got buy-in, they were able to get 72% of their late people versus 37% when all that started. So pretty interesting, exciting stuff. Now, last little piece, I have to throw in my 2 cents of just kind of my time here and for trainees and the people to follow me. So there's been a lot of talk about mentors, right? I think almost every single chief resident here, and certainly we've had lots of lectures in just the last 2 or 3 years about mentorship. It's a buzzword in surgery, right? And I think rightly so. But I actually, and where I started thinking more about this was after Dr. Freshlag's grand rounds. This was probably about 2 years ago, but she talked about not only mentorship, but talked about these other pieces, right? The mentor, the coach, and the advisor, and what each of those meant and how they're different. Then I actually add and think that it's important to have an advocate for you, okay? So I think, it's a little bit more complicated than just the mentor piece, but let's kind of go through them real quick. So a mentor, I'm not going to belabor. We all know what a mentor is. Somebody who's willing to teach for you, one that has expertise in what you're doing, is motivate you, blah, blah, blah. Important piece at the bottom there is the mentor will allow you or even encourage you to choose your own direction, offer guidance that takes into consideration your personal situation, the needs, and your passions, right? So that's a true mentor. They know you. They're going to guide you based on who they know you are. Versus an advisor is someone that has a area of expertise, somebody who's going to kind of push you or tell you their opinion and where to go. It's also oftentimes a very short period or duration of relationship that you have this. And a coach, which this is the first time I heard the coach was with Dr. Freshlake, right? This is the person that is going to keep pushing you. Not, oh, you did a good job here. It's like, no, you can do better. You need to be more efficient here and do this and constantly push you to that next level, right? They're unemotional. They're not really doing it because they think it's, that's who you are and your passion or whatever. They want to just get you better, right? So after Dr. Freshlag's lecture, and everyone has their own, right? We'll get to it. But after Dr. Freshlag's lecture, I was still general surgery at the time, and I went straight up to Dr. Bold, and I'm like, I want you to be my coach. Kick me in the butt when I need it. Don't tell me I do a good job and give me a hug, right? I want you to push me and tell me what I can do better to be a better surgeon. And then an advocate is the person that puts your name in the hat always, right? So Dr. Cook, for me, has been fantastic at this. This is one of the main reasons I stayed at UC Davis, was Dr. Cook had done this for me for 7 years, where your name comes up. Oh yeah, Sterling might be interested in doing that study. Oh, Sterling would like to be the resident representative of the ACS. All those kinds of things. And I think to have a successful career, finding those people is crucial. And I don't think it's very well talked about. So again, these people, and you can have ones at all of it, right? Again, Dr. Cook for me has been all 4 of these. Dr. Brown, all 4 of these. Dr. Young, all 4 of these. And each individual is kind of, here or there, might be a mentor here, sometimes an advisor, sometimes the coach, so on and so forth. But it's dynamic, right? We all have this. A lot of it happens naturally. But I think it's important for people as you go through in your careers to think about these things. I can tell you by just getting a job that this is what matters more than how you did on your ABSITE back in January, right? No one cares. No one asked me what I got on my ABSITE in any of my job interviews. And then the last statement that I want to leave you guys with here is, just kind of reflection on doing this. And I think, learn like a baby, right? So this actually comes from Carol Dweck. She didn't say learn like a baby, but she talks about in some of her books. She's a very preeminent psychologist, that does learning. And she has this book, Mindset, that I encourage everyone to read. And she talks about these kind of ways of teaching and learning of a fixed mindset and growth mindset and so on and so forth. But I like how she says this. Babies don't worry about making mistakes or humiliating themselves. They walk, they fall, they get back up, right? They don't care who's in the room or who's watching them fail. They just barge forward. What can put an end to this is a fixed mindset, meaning that you don't want to do that. You hide behind, yourself, basically, and you get in the way of yourself. You've heard multiple chiefs talk about that. If they can do something different, they would ask more questions, right? Do that. Don't be afraid to fall. So like I said, I'm going to Sutter next year. I'm going to do general thoracic surgery and complex foregut. So I'm just going to be down the street. Certainly it won't be strange. It'll still torture most of you here. This is kind of a tongue-in-cheek thing that Dr. Brown, Dr. Cook, and I always talk about. She'll be in the operating room and say, that she's teaching the enemy all her tricks. And I just say, don't worry, I'll use it for good, not evil. All right. And that's it. Let's see if we can get this to play. He is very white, but he's mine. That's all I got.